You are lying in a hospital bed. It has been 3 days, maybe 4. The nurses are kind, the doctors are attentive. You're not in crisis anymore. The procedure went well, the infection is responding to treatment, and sometime in the next day or two, the attending physician is going to walk in, smile, and tell you that you're ready to go home. And you will feel relieved. You will call your spouse. You will think about your own bed, your own kitchen, your morning coffee routine. You will feel grateful that modern medicine caught it in time, grateful that you have Medicare, grateful that after 40 years of working and paying in, the system finally showed up for you when you needed it most. What you will not know, what almost no one in that bed ever knows, is that a single word in your hospital file, one administrative classification you were never shown, never explained, and never asked to approve, is quietly building a bill that could cost you $10,000, $30,000, or more. And Medicare won't pay a cent of it, not because you did anything wrong, not because you chose the wrong plan, but because of a rule so obscure, so deliberately invisible, that even experienced nurses and hospital social workers sometimes don't fully understand it until it's too late for their patients. In 2026, that rule just got sharper teeth. Here is the trap. When you are admitted to a hospital, you are either classified as an inpatient or placed under something called observation status. On the surface, these two things look identical. Same room, same bed, same nurses, same IV, same hospital bracelet on your wrist, but underneath the surface, they are two completely different financial universes. Inpatient status means Medicare Part A covers your stay. It means that if you need a short-term stay in a skilled nursing facility after discharge for physical therapy, wound care, medication management, Medicare will cover up to 100 days of that care, with only a modest copayment after the first 20. Observation status means none of that applies. Under observation status, your hospital stay is billed as outpatient care under Medicare Part B. Your deductibles are different. Your cost sharing is different. Your drug coverage inside the hospital is different. And in many cases, the medications you receive during your stay are billed to you directly at retail prices because Part B covers them differently than Part A. But the cruelest consequence of observation status has nothing to do with the hospital bill itself. It has to do with what happens after you leave. Medicare has a rule, one of the most consequential rules in all of retirement healthcare, called the 3-day inpatient requirement. To qualify for Medicare-covered skilled nursing facility care after a hospital stay, you must have been formally admitted as an inpatient for at least 3 consecutive days. Days spent under observation status do not count. It does not matter how sick you were. It does not matter that you slept in that hospital room for 5 nights. It does not matter that a doctor ordered every test, every medication, every treatment, and every procedure during those days. If your status was observation, those days are invisible to Medicare when it calculates your skilled nursing facility eligibility. So here's what happens. You spend 4 days in the hospital recovering from a fall, a stroke, a cardiac event, a serious infection. You are discharged, but you are not ready to go home alone. Your physician recommends a skilled nursing facility for 2 to 4 weeks of intensive rehabilitation. You agree, your family agrees. It seems like the logical, medically appropriate next step. And then the bill arrives. Because you were under observation status, not inpatient, Medicare Part A will not cover a single day of that skilled nursing facility stay. The average cost of a skilled nursing facility runs between $300 and $500 per day. A 3-week stay can cost $9,000 to $15,000. A month can cost $20,000 or more, out of pocket, without warning, presented to you or your family after the care has already been delivered. This is not a hypothetical. This happens to hundreds of thousands of Medicare beneficiaries every single year. And in 2026, with new CMS billing guidance and updated hospital compliance pressures, the number of patients quietly classified under observation status is rising. Let's break down exactly how the damage compounds because it doesn't stop with the skilled nursing facility bill. Hospitals have powerful financial incentives to classify patients as observation rather than inpatient. Medicare auditors, under a program called the Recovery Audit Contractor Program, penalize hospitals for inpatient admissions that auditors later deem medically unnecessary. To protect themselves, hospitals increasingly default to observation status for stays that fall into gray areas, and nearly every short-term medical stay falls into a gray area. The 2026 updates to CMS guidelines have tightened the criteria hospitals must meet to justify inpatient admission. This means more borderline cases are being pushed into observation more quietly and more automatically than ever before. You will not be handed a form that says, "You are now on observation status." You may receive a standardized notice buried in a stack of admission paperwork, the Medicare Outpatient Observation Notice, or MOON. But studies show that most patients don't understand it. Many don't receive it at all, and almost none understand its financial consequences in the moment. While you're in the hospital under observation status, your care is billed under Part B, not Part A. That means you are responsible for 20% of every covered service after your Part B deductible. For most Medicare beneficiaries, that deductible in 2026 is over $240. The 20% cost sharing has no cap unless you have supplemental coverage, and prescription drugs administered during your stay. In many cases, those are billed separately under Part D rules, meaning the drugs your nurse brings you each evening may generate a separate bill you weren't expecting at all. This is the phase that destroys retirement savings. You or your spouse is discharged into a skilled nursing facility needing weeks of rehabilitation. The family assumes Medicare is covering it, because why wouldn't Medicare cover medically necessary care that a physician recommended following a serious hospital event? But Medicare is not covering it. And by the time the family discovers this, week 1 is already done, the care is ongoing, and the alternatives, moving the patient, disrupting recovery, bringing them home before they're ready, feel impossible. So the family pays. They pull from savings, they liquidate an IRA, creating a taxable event on top of the care costs. They drain accounts that were meant to last another 20 years or that were meant to pass to children. Some families, after a single unexpected extended skilled nursing facility stay, find themselves on the edge of Medicaid eligibility, not by choice, not by plan, but by exhaustion of everything they had. One hospital stay, one classification, one word they never knew mattered. Let's look at what this actually costs two real families. Dorothy is 74. She falls at home, fractures her hip, and spends 5 days in the hospital. On day 2, a nurse mentions something about observation status, but Dorothy assumes it's routine paperwork. She nods. She signs. She is discharged to a skilled nursing facility for 4 weeks of hip rehabilitation. Her family assumes Medicare is handling it. The bill that arrives 6 weeks later is $28,400. Medicare paid none of it. Dorothy had savings, but not $28,400 in liquid savings. Her daughter liquidates part of Dorothy's IRA. The withdrawal, combined with Dorothy's Social Security and pension income, pushes her into a higher tax bracket for the year. The actual cost with taxes ends up closer to $37,000. Now meet Harold. Harold is 77. He has the same hip fracture. He spends the same 5 days in the hospital. But Harold's son had watched a video like this one. He knew to ask. The morning after Harold's admission, his son spoke directly to the hospital's patient advocate and asked one specific question: "Is my father currently classified as inpatient or under observation status?" The answer was observation. The son requested a formal review. The attending physician agreed that Harold's condition warranted inpatient admission under current CMS criteria and updated the classification. The change was made on day 2. Harold's 4-week skilled nursing facility stay cost the family $480 in co-payments. The standard Medicare Part A cost sharing after day 20. Not $28,400, not $37,000. Same fall, same hospital, same rehabilitation facility, same 4 weeks of care. One question made a $37,000 difference. So what do? How do you protect yourself and everyone you love? This is your defense plan, and it starts before you ever set foot in a hospital. First, know the phrase before you need it. The moment you or a family member is admitted to a hospital, ask immediately and directly, is this patient classified as inpatient or under observation status? Do not assume. Do not wait for someone to tell you. Ask it by name. Second, request the MOON notice in writing. Hospitals are legally required to provide the Medicare Outpatient Observation Notice to patients on observation status within 36 hours. If you are on observation status and have not received this notice, request it, read it, understand what it means for your skilled nursing facility eligibility. Third, if you are placed on observation status, Ask for a physician review immediately. The attending physician has the authority in many cases to reclassify a patient as inpatient if the clinical documentation supports it. This is not always possible, but it is always worth requesting, and it must be requested early, not on the day of discharge. Fourth, if your inpatient reclassification is denied, file a written appeal. Under the Notice Act, you have the right to appeal an observation status classification. The appeal process is not guaranteed to succeed, but it is your legal right, and it must be exercised quickly. Fifth, review your Medicare supplement or Medigap coverage right now before a hospital event occurs. Some plans offer limited skilled nursing facility coverage even without the 3-day inpatient requirement. Medicare Advantage plans vary dramatically on this point. Know what your plan covers and what gap remains while you are healthy, not while you are in a hospital bed trying to absorb information under stress. Sixth, if you have a spouse, aging parent, or anyone in your household approaching Medicare age, share this information now. The most dangerous version of this trap is the one where the patient is too sick to advocate for themselves, and the family doesn't know the right question to ask. Write down the phrase. Put it in your phone. Put it in the file where you keep your Medicare card. Is this patient classified as inpatient or under observation status? 6 words, potentially tens of thousands of dollars. Medicare was built to protect you. But it was also built with rules, complicated, counterintuitive, financially brutal rules that the system is not required to explain to you in the moment you most need to understand them. The observation status trap is not new. But in 2026, as hospitals face increased audit pressure and CMS tightens inpatient criteria, the number of patients quietly slipping into observation status is growing, and the savings that get drained, paying for care that Medicare should have covered, savings that took 30 or 40 years to build, don't come back. You cannot undo a hospital classification after discharge. You cannot retroactively protect a skilled nursing facility bill that's already been issued. You cannot unliquidate the retirement account that got emptied to pay for care that a single phone call on day 1 might have prevented. But you can know, right now, today, before any of this happens to you. Save this video. The day you or someone you love ends up in a hospital, you will want to come back to it. Send it to your adult children, to a sibling, to anyone who might be the one making decisions in a crisis moment when clear thinking is hard and the stakes are everything. Because this is not a scare, this is a warning, and there is still time to use it. Subscribe for more retirement and Medicare warnings, because the rules keep changing and the system is counting on you not knowing.